Well, I just want to say 4 things about Jackie's presentation. She was informative, illuminating, insightful, and entertaining. So thank you very much. I only had 3, but then I made one up. Richard Gottfried. Assembly member Dick Gottfried represents Chelsea, Hell's Kitchen, Murray Hill, Midtown, and part of the Lincoln Center area in the New York State Assembly. He has chaired the Assembly Health Committee since 1987 and is a leading state health policy maker not only in New York, but nationally. He was a major architect of the state's managed care reforms and continues to champion stronger protections for consumer and healthcare providers and universal access to quality, affordable healthcare. Dick Gottfried, you want to come up and?
Well, good afternoon. Having been part of the advisory body to this project, for me was really a terrifically enjoyable and valuable process, because I felt that I learned an enormous amount about community health workers that I never knew before, and I continue to find it exciting to be part of what I believe will be the development of this as one of the newest and most important parts, I think, of New York's healthcare system as we go forward. I want to first of all just say a couple of things about the New York State Health Foundation, which is one of the groups that has been funding and supporting this whole effort. I don't mean to suggest that they are more important or were more involved than the various other entities that are on the letterhead of this effort, but they are, I guess, one of the newest participants in the healthcare scene in New York. It is a foundation that was created by the New York State Legislature as part of the effort. I guess it's now almost 10 years ago, when Blue Cross converted from being a nonprofit company to being a for-profit company. And one of the things that happens when things like that happen is a huge chunk of money is siphoned off for the quote-unquote public good. And most of that money in the Blue Cross conversion went to help pay for the state Medicaid program for a couple of years, in particular for the to enable hospitals and others to negotiate a good contract with 1199. A good thing. Let me make that clear. But many of us felt that the bulk of that money should have been put into a new foundation, as they did in California, that would be able to fund a variety of initiatives in the health area. And a very tiny sliver of the money did indeed get put into creating what became the New York State Health Foundation. It was set up with a board that would basically have essentially 3 voting members, one appointed by the majority party leadership in the Assembly, one by the majority party leadership in the state Senate, and one by the governor. I was about as certain as could be that that pot of money was basically going to be, some might call it a slush fund for the 2 legislative leaders and the governor to dole out money for their favorite projects, and that it would not be a particularly creative engine for New York. I am as still, to this day, 10 years later, about as, well, I guess it's only 7 or 8 years later, about as astonished as I can be and utterly delighted that the foundation, in fact, somehow turned itself into a real foundation. That actually, and I wish I could take credit for that, except I can't, because I didn't think that was what was going to happen. It has, I think, so far exceeded anybody's expectations in terms of the quality and the creativity and the impact of the things that it has funded. And I think this community health worker program is a terrific example of that. The healthcare system, I hope, and I think an awful lot of people hope, is moving in some extraordinary new directions. And we're doing that for a variety of reasons. One is that, healthcare has gotten a whole lot more important and complicated than it ever was. It is also a whole lot more expensive than it ever was, and there is a desperate desire to both help people take advantage of this increasingly complex and hard to navigate system and get the care they need when and where they need it, and also to control the cost of this system, but to control the costs in ways that do not deprive people of the care that they need or deprive the people who deliver that care of a reasonable income. And there is a growing recognition that the way to accomplish both of those goals is to accomplish them together, and to do that by building increasingly integrated systems of care delivery and care coordination and care management, so that everyone in the system has a primary care practitioner, and I say practitioner because for some people it'll be a physician, for some it'll be a nurse practitioner, for some it may be a physician assistant, and that person be linked into all of the other care that person needs, and that there be people involved in the process to help make sure that that person is getting access to all the services that are available and needed, and is following what their primary care practitioner or specialist recommended for them, that they stay on their meds, that they stay on their diet, that they get the exercise they need, that they do all of the things and that they ought to be doing, and that when they need even a small piece of care, that it gets to them so that whatever is wrong with them doesn't snowball to the point where they end up in an emergency room or a hospital bed, costing society vastly more than if society had paid attention to their problem when it was small and more easily treated. If we can build such a world, and I believe we can, and I believe there are a lot of people who are hard at work at doing that, and I think the Governor Cuomo's administration's Medicaid redesign team, which has many flaws in its operation, but I think is well focused on this concept of integration and coordination and management, so that costs are saved in ways that simultaneously produce better outcomes. There are a lot of people working on making this happen. For this to happen, I believe you can't, I don't think you can make such a system work only with the traditional groups of participants that we have had for the last 1,000 years. I believe that even with all the wonders of electronic health records and health information technology and all that, which is wonderful and will enable us to do a lot of things that 5 years ago we couldn't do, we're going to need people who just about exactly fit the description of community health workers. And so it is extraordinarily important that at this moment in the transition and transformation of our healthcare system, here we are setting to work to make sure that at least in New York State, we build the profession of community health workers because we urgently need them. Now, this is not the first time in recent years when we have sort of discovered that we needed a new category of folks and set about to create them. Probably about 40 years ago or so, if you had talked to someone about home health care aides, people would have looked at you and said, "What? Do you mean like nurses that come to your house?" "Well, no, not quite nurses." "Well, do you mean like a maid or a butler?" "Well, no, not that either." "Well, what do you mean?" Because 40 or so years ago, I don't think we, as far as I know, I don't think we had a whole lot of people who today we would call home health care workers of various kinds. And today we have tens of thousands of them in New York State, and at least on behalf of my mother, I think it's a really good thing that we invented that profession several decades ago. We didn't invent it all at once. It took a while to work out what home health aides are allowed to do and what they're not allowed to do. And by the way, we're not finished with all of that thinking, even though the book of all, which I've seen, of all the things that home health care aides are allowed and not allowed to do without crossing into the line of what nurses do, et cetera. It's a pretty thick book. I'm glad I don't have to master it. Although I have looked into it, again, on behalf of my mother. Funny how all things revolve around, our own personal situations. But we gradually worked out what they could and couldn't do. We have in recent years developed rules about the training that they need to have and certification, and recently we added, fingerprinting and stuff like that, which, maybe we could have done without, but it took us a number of years, and it's still a work in progress. We still don't pay them anywhere near as well as we ought to. But a whole profession that didn't exist not many years ago is now an indispensable part of the lives of, tens, hundreds of thousands of New Yorkers. Now, I'm not, there are a lot of differences between what community health workers will do and what home health aides do, et cetera, and I'm not, comparing the two, other than on the example that we are, hopefully it'll take us less than 40 years, to create a whole new line of work. And yes, many of you have been out there for years doing this line of work, but we need thousands and thousands more of you. And it's going to be increasingly important that there be a definition of what CHWs are and what they do. Because right now, I don't know how many conversations I've had just in the last few months, because people say to me, "Dick, what's this meeting you're going to?" And I say, "Well, it's about community health workers." And people, "It's about what?" And then, of course, it takes a few minutes to explain. It would be certainly a lot easier on me if when I tell people I'm going to a meeting about community health workers, they didn't know, say, "What?" So it's important that the world come to understand what CHWs are. It's important that we figure out what kind of training one ought to have to do the description of the job that we create. It's going to be important that we create a mechanism so that when somebody shows up looking for a job and says, I'm a community health worker, hire me, it would be really important if we could say, do you have one of those certificates from the state of New York? As we can ask someone who wants to be a home health aide. And of course, it would be pretty nice if we found ways to pay community health workers other than having a grant that lasts for a couple of years and you're constantly wondering whether the grant is going to be renewed. In the process of creating a training and certification standards or requirements, it's also important that we pay attention to the fact that there are a lot of people out there today doing work that will meet the description of a community health worker. And while it's important to set standards and requirements going forward, it's also important that we not basically toss aside the people who have been doing this kind of work and pioneering the community health worker field. And even though they may not have gone through the new definitions of training and whatnot that we're in the process of doing, I think we're going to need to find an appropriate middle ground that enables them to keep doing their work on our behalf as the newer models of training and certification go forward. But if the healthcare system that we are moving into is to have what I believe it desperately needs, namely the help of community health workers to help with care coordination and management and navigating the system and getting people the care that they need and the benefits that they need, et cetera, we're going to need to put the profession on the map. And that is a lot of what these recommendations are all about doing. You know, on the question of financing, you know, we are hopefully leaving the world of, although it's going to take a while, of fee-for-service payment for medicine. The shortest explanation I've heard of why we should move away from fee-for-service medicine was written by George Bernard Shaw over 100 years ago when he said, the trouble with our system is that the more of you the doctor cuts off, the more we pay him. And he said, you know, that system makes sense if you're talking about encouraging bakers to bake more bread, but not if you cherish your body parts. So I don't think community health workers are going to be paid on a fee-for-service basis, nor should they, because community health workers, in the nature of things, work all the time and work in big pieces and tiny pieces and making phone calls and visits. And to try to compensate that on a fee-for-service basis is never going to work, and we shouldn't try. And of course, people are going to say, well, where are you going to find the money to pay these people? And you know, I would say ask the question, every hospital has a CEO. Every hospital, who of course gets paid a whole lot more than any community health worker, probably than any 100 community health workers, some of them. You know, every hospital has an army of accountants. Every hospital nowadays has an army of computer technicians, although not too many years ago, none of them did. And you might say, well, how can hospitals pay for these people? How can hospitals pay for maintenance workers or a whole lot of other people? I mean, I'm not only talking about the people at the top of the pay scale. Well, the answer is, and not just hospitals, you could say, how do community health centers pay all of their people? The answer is, if the system can't operate without person X. The system will find a way to include the salary for that person in its cost structure. And, you know, if hospitals didn't have accountants and computer techs, they could not operate. They could not take in the money they take in. They could not pay their bills. We are building, I believe, a system in which if physician offices and community health centers and hospitals and integrated delivery systems and ACOs, whatever structures we create, if they don't have community health workers, they will not be able to function, and or function in an efficient and quality way. And therefore, I don't want to say if we build it, they will pay for it, but I'm pretty confident that the system is going to be required for its own survival to figure out a way to pay for community health workers, and not just by, you know, 1 or 2 year grants that leave everybody at the edge of their seat wondering whether they're going to have a job next year. And I think what we can all contribute to helping make all of the things that I've just talked about happen is by building the profession, by implementing the recommendations in the report, by organizing the profession statewide, not just in New York City and Rochester, 2 wonderful communities, but, you know, there's a lot of New York in between. And that is what this whole event is all about, and that's why I find this so exciting.